meeting is being recorded.
Good evening, everybody. Welcome to the first Spice Root classroom session for the year 2023. So we are starting out with this case presentation hosted by the Spice Root Tamil Nadu chapter. We have an interesting case of the respiratory system, which we will be discussing today. This whole session has been organized by Dr. Hariharan. He's the PG coordinator for the state of Tamil Nadu. And very promptly and actively, he took this upon himself and organized the session in hardly about a week or 10 days' time. So he has recently graduated from Meenakshi Mission Hospital, Madurai. And over to you, Hari, to introduce our team, and then let's start the discussion.
Thank you, ma'am. I thank Spice Root India for giving us the opportunity for Tamil Nadu chapter to host this month's academic session. And today, I thank Dr. Pranitha ma'am, our favorite professor from Meenakshi Mission Hospital, senior consultant in the Department of Family Medicine, Meenakshi Mission Hospital Research Center at Madurai. She is also an NB examiner. She'll be moderating the session today. And I will introduce Dr. Adila. She is our first year resident from, doing DNB Family Medicine from Meenakshi Mission Hospital and Research Center, Madurai. So shall we begin, ma'am?
Yeah, Hari, we can begin. Yeah, presenter can start.
Okay, Adila, you can start presenting. Thank you.
Thank you, sir. Actually, thank you for giving me this opportunity. I'm going to start, sir.
Adila, you can share your screen.
Ma'am, I'm trying, ma'am.
Okay.
Some error. Yes, sir.
Not getting it, Shabila.
Ma'am, actually, I'm not able to connect, ma'am.
Adila, you can send that to Hari. Maybe Hari can share the slide.
Yeah, Hari has it. Hari, can you share? I may not be able to share. Adila, you had just tried, it happened, no? Maybe you refresh or you try again.
One minute, ma'am, I'm trying.
We tried it when she logged in.
Adila, you want me to connect?
Actually,
I think better, Hari, you can connect something.
Yeah, start, then check.
Hello, ma'am, can you
visible?
See?
Yes.
Yes.
Okay, ma'am. So I'm going to present. I'm Dr. Adila, DNB resident from Meenakshi Mission Hospital in Family Medicine. I'm going to present a case of a 30-year-old male patient who is a daily wage worker by profession with no known comorbidities, who is a chronic alcoholic and a chronic smoker. The presenting complaints: weight loss since 3 months, fever since 20 days, cough with expectoration since 1 week, and breathlessness since 20 days.
Okay, Attila, just wait. Just Attila, you just repeat the history one more time. You are a little fast.
Okay, ma'am.
Ah.
A 30-year-old male patient who is a daily wage worker by profession with no known comorbidities, who is a chronic alcoholic and a chronic smoker,
Okay,
came with
so I
complaints
just
of
want you to I just want you to ask, what do you mean by chronic alcoholic and chronic smoker?
Actually, ma'am, this patient is smoking 1 pack of cigarette per day since for the past 11 years, and this patient is also having 350 ml of alcohol per day for the last 11 years.
Okay, do you know the safe limit of alcohol for a patient? Safe limit of alcohol.
And for females, it is 14 units. For females, it is 14 units, and for males, it is 18 units.
Okay. Okay, proceed. Be a little slow so that everybody can. Okay.
Okay, ma'am. Presenting complaints: weight loss since 3 months, fever since 20 days, cough with expectoration since 1 week, breathlessness since 2 days, ma'am. History of presenting illness: this patient had complaints of a weight loss. He had lost weight of more than 6 kg since last 3 months. It was associated with the loss of appetite also. And the patient also had complaints of a high-grade fever associated with chills and rigor, intermittent in nature, and he also noticed evening rise of temperature since the past 20 days. Patient also complains of
Complaints of, tell me.
Complaints of cough, which is of gradual onset, productive in nature, and it increased in severity, and also that there is no postural or diurnal variation noticed for cough.
So why do you ask for diurnal variation in cough?
Actually, in bronchial asthma, there can be increased cough in the night and early morning hours.
Is there any variant of bronchial asthma? Usually they do present with breathlessness. What is another variant of bronchial asthma which is known?
Cough variant bronchial asthma can be present.
Yeah. Okay. So one other thing, you have told about weight loss. So when do you say it is a significant weight loss in a patient? A month weight loss of a kg or 1.5 kg is normal. So how do you define weight loss?
Significant weight loss means losing weight of more than 10% of the person's weight in 6 months, or more than 5% of weight in 5% of actual person's weight in 3 months. Then we can say it's significant.
Significant weight loss. Okay. Then you have already commented about saying the patient had got fever, high-grade fever with evening rise of temperature. So can you name some conditions in which there is evening rise of temperature with chills and rigors?
Tuberculosis can present with evening rise of temperature, and in malaria, patients can have a fever with chills and rigor. Pneumonia, patients can have a fever with chills and rigor. That's it.
So that in UTI also there can be presentation of fever with chills and rigors. So the most common conditions with evening rise of temperature with chills and rigors will be tuberculosis, malaria, and UTI. Most common. So the other things can be taken, but the first three has to be often told for examinations. Okay. Then how do you define cough? You've told cough. Tell me about the cough. How was it? Whether it was protective?
Gradual onset of cough. It was productive in nature, ma'am. It was productive in nature, associated with the scanty sputum, ma'am. Productive in nature, associated with the scanty sputum, which is of mucoid in nature. It was not associated with any blood-stained sputum.
Okay. So, it was not a protective cough. So, can you name some condition in which there is a pink sputum?
Pulmonary edema, acute pulmonary edema.
I can't hear you properly, ma'am.
Acute pulmonary edema, ma'am. Hello, ma'am, can you hear me?
Yeah, now tell
Hello,
me.
ma'am, can you hear me?
Yeah, tell me. Yeah,
Ma'am,
tell me.
acute pulmonary edema can present with pink sputum, ma'am.
Pink frothy sputum. Okay. So can there be blood-stained sputum? Name some conditions where there is blood-stained sputum.
Blood-stained sputum can present in tuberculosis,
Okay.
malignancy, and any
Okay.
injury to the local areas.
So any condition which is related to kidney, blood in sputum? Kidney? What about vaginous? Yeah, vaginous granulomatosis, blood-stained sputum, and it is related to kidney. When there is a local injury to the bronchus or esophagus, you can have blood-stained sputum. Okay, so you have told about, yeah, you've told about breathlessness. What is the classification for breathlessness?
Actually, in respiratory system, breathlessness can be classified according to MHRC scale. It is grade 0 can be dyspnea on heavy exercise. Grade 1 dyspnea on walking on hurrying on level road or on climbing steps. Grade 2 can be dyspnea on the patient walks slowly than the peers of same age group, as the patient needs to stop in between for breathing. And grade 3 can be patient can have breathlessness even on walking for 100 yards. And grade 4 can be patient can have a breathing difficulty even at rest.
Okay, so for this patient,
Hello?
What is your grading of breathlessness?
Can you hear me?
Yeah, I'm hearing. For this patient, what is the grading of breathlessness?
And this patient was having grade 4 breathing. Initially it was grade 2, then it progressed to grade 4 on presentation.
Okay, so name some condition in which there is acute onset of breathlessness. Now it has progressed from grade 2 to grade 4 in this patient. Name one condition where there is acute onset of breathlessness. What do you suspect? A patient comes into the casualty with acute onset of breathlessness. What is your first probable diagnosis on the patient?
Acute pulmonary edema can present with acute breathlessness, pulmonary embolism.
Yeah, very good. So pulmonary embolism has to be suspected in a patient with acute onset of breathlessness within hours. So what is the finding on pulmonary embolism in ECG?
In pulmonary embolism, there can be S1, Q3, T3 in ECG.
So, yeah.
SK in V1, lead 1, Q wave in lead 3, and T wave in version T3.
So, yeah,
Hello.
true. So, good. So, whenever a patient comes into the casualty with acute onset of breathlessness, so you should ask the history whether of pulmonary embolism, whether the patient was bedridden, whether the patient had undergone surgery, whether the patient was on oral contraceptive pills. So when you are suspecting pulmonary embolism, you're supposed to send D-dimer as well as your ECG. So ECG is going to show, as you said, S1, Q3, T3. And what about the D-dimer values? In pulmonary embolism, how will be the D-dimer?
It will be very high than 3,000 to 5,000.
Okay, so it is usually the normal is around our hospital normal levels is around 400 to 500. So we do suspect pulmonary embolism and the D-dimer levels are high at around 1,000, 1,500 to 2,000. Okay, so if it is pulmonary edema, so what if it is pulmonary edema? How do you treat a patient with acute flash pulmonary edema?
Giving diuretics, ma'am.
Yeah, giving diuretics. So if it is due to hypertension, yeah, if it is due to hypertension, you are supposed to control
hypertension.
Yeah. Okay. So what is the drug of choice for acute malignant hypertension?
acute.
Malignant hypertension. What is the first drug of choice?
Calcium channel blocker, nifedipine can be given.
So it is usually labetalol, no? IV. So the first we usually start with labetalol IV drip. IV.
Yes. Okay, ma'am.
Okay.
Okay, ma'am.
Okay. So then proceed.
Okay, ma'am. The patient also complains of a breathing difficulty, which is of incidence in onset, gradual progression, and it is more on lying towards the right side. And so the patient always prefers to lie on left side. And there is no complaint of hemoptysis.
No complaints
No
of?
hemoptysis, ma'am.
Okay.
No complaints of palpitation, no complaints of chest pain, orthopnea, PND, syncope, or pedal edema. There is no history of any weakness, seizures, altered consciousness, or headache. There is no history of any nausea, vomiting, abdominal pain, melena, loose stools, or history. There is no history of similar illness in the past. No history of any pulmonary tuberculosis, bronchial asthma, diabetes, or hypertension in the past in this patient. Actually, this patient was put in de-addiction center for a chronic, as the patient is a chronic alcoholic. Three months. The patient had a contact with a pulmonary TB, smear positive pulmonary TB patient from there.
Okay.
And coming to family history, patient is there is no history of any similar illness in the family, no history of any pulmonary TB, bronchial asthma, or diabetes or hypertension in family. Coming to personal history, patient used to take a mixed diet, decreased appetite. He's noticed to have decreased appetite since 3 months. Patient is having disturbed sleep since 1 week as due to cough. Patient is a chronic smoker. He smokes 1 pack per day for 11 years and a chronic alcoholic. That he used to take 350 ml of alcohol per day for 11 years.
Okay.
Patient's bowel and bladder habits are regular.
Okay.
Now coming to drug history, patient is not taking any regular medications, and he is not known to have any drug allergy.
Okay.
Coming to socioeconomic history, patient is an unskilled daily wager. He lives in a kacha house with 2 rooms. There lives 5 persons, including the patient. There are 2 earning members in family. Income can be 800. Income is 800 rupees per day. And they are using fuel wood at home. There is no pets at home.
Pets at home. Okay. Now, what is this? Why do we worry about socioeconomic status in this patient?
Actually, the patient is from a lower middle class background, so there is high chance of getting infections and other infectious diseases.
Small house, because it's a small house, they live in a very small rooms, so chances of infection of tuberculosis is more. Overcrowding. Okay, so you were telling about the daily wager. He was a daily wager. So what is the importance of asking that history?
Here already 5 members are there and only 2 earning members in family. So with this income, they are not able to meet the daily, meet the nourishment of the family. So there can be malnourishment, which can predispose to some other diseases.
Yeah, true. Very good. Next, proceed.
Coming to general physical examination, patient is conscious, oriented, febrile, tachypnic, moderately built and ill-nourished, pallor present, no icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. Vitals, pulse rate 120 beats per minute, regular, normal volume and character, vessel wall not thickened, all peripheral pulses can be felt. BP 120 over 80 mm of Hg, recorded from right arm in sitting position. Respiratory rate 40 beats per minute, regular, abdominothoracic, no signs of respiratory failure. Saturation 93% on room air, 97% with 5 liter O2. temperature was 100 degree Fahrenheit on examination, and
Okay.
JVP was not used.
Okay. Now, in this patient, you have told about the respiratory rate of 40. So, what is a normal respiratory rate in an adult?
Normal respiratory rate can be 14 to 18 per minute.
Okay. So, the respiratory rate is 40 in this patient. Was he comfortable sitting? Or did he need oxygen? The patient you had commented that the patient's respiratory rate is 40 per minute.
Yes, ma'am.
Was he comfortably sitting or did he need oxygen?
Yes, ma'am. He needed oxygen.
So he
Only
needed
after
oxygen.
giving yes, ma'am.
Okay. So, okay, good. Then why did you comment about JVP in this patient? It's a respiratory case. Why were you worried about JVP?
Ma'am, actually the patient presented with breathlessness and cough and all, and tachypnea. So to rule out any cardiac causes, we have to look for JVP.
Okay, very good. Next. Next slide. Proceed.
As the patient presented with breathlessness, cough, and fever, and also tachypnea, desaturation was there. So the probable system involved can be respiratory system. So
Okay.
coming to respiratory system examination, upper respiratory tract, nose and paranasal sinuses appears to be normal. No congestion, no sinus tenderness was present. Oral cavity, oral hygiene was not maintained. Caries tooth were present. Pharynx was not congested. No tonsillar enlargement was present.
Okay, so I just wanted to ask you, there is a contact history of tuberculosis. What other comorbid conditions in your general examination and from the respiratory system general examination can predispose to TB infections?
In this patient, ma'am.
Yeah.
Okay, the patient is a malnourished patient.
Okay.
And as the oral hygiene was not maintained, caries tooth and all this can predispose to like immunodeficiency and other. It can predispose to tuberculosis, such infections.
So this point I just wanted to tell you. So whenever there is an immunocompromised status, we usually think of diabetes and HIV. So you should even this point, like the oral hygiene, dental caries also is a predisposing factor for tuberculosis infection. So that's why I wanted to underline this point. Okay.
Okay, ma'am.
Okay. You can get next. You can go to the next point.
Now coming to lower respiratory tract, on inspection, trachea appears to be deviated to right side. Right side sternocleidomastoid muscle was prominent. No supraclavicular and infraclavicular hollowing. Chest movements were decreased on left side. No rib crowding. No scar. No dilated veins or visible pulsations over chest. Apex beat could not be appreciable. No drooping of shoulder or prominence of scapular border can be noticed.
Okay, so you have told about the trachea deviation to the right side. So what does it tell you? Trachea shifted to the right side. What does it tell you?
Actually, there can be there can be left-sided effusion or a pneumothorax, or there can be right-sided fibrosis, collapse, or
So the
lung
trachea,
pathology,
true.
parenchymal lung pathology.
Yeah, okay. So what you have told about dilated veins on the chest. So in what condition do you have dilated veins on the chest?
Dilated veins can be present in SVC obstruction.
Yeah, true. Okay, so second thing is you were telling about supraclavicular hollowing. In which condition you will have supraclavicular hollowing?
All those are signs of poliomyelitis. So in case of fibrosis,
Okay,
in
true.
cavity,
Okay,
cases,
so in case of fibrosis, you have supraclavicular hollowing. So there was no crowding of ribs. So in which condition do you expect crowding of ribs?
fibrosis.
So it can be fibrosis. Okay. Anything else?
I don't know, ma'am, actually.
Okay, read about it. Next, you were telling about no nodes palpable. Did you tell any nodes?
No, ma'am, no lymph nodes were palpable.
Okay, so there is a node which is palpable on the clavicle, above the clavicle. So what is that sign called?
Ma'am, Virchow sign.
Tertiary sign. So it is usually seen in?
Ma'am, gastric carcinoma
Yeah. So
patients
it is
can have
seen,
supraclavicular lymph nodes.
yeah. So it is seen in CA stomach. There is a node called as Virchow's node. The sign is called as Tertiary sign. Okay.
Eyes, ma'am.
Okay. Okay. Then you proceed to palpation.
Okay. Okay.
Mhm.
On palpation, trachea is deviated to right side. Apex beat was not palpable. Chest movements decreased on left side. Chest expansion was 1 centimeter. No intercostal tenderness over chest. Vocal fremitus was decreased on left mammary, axillary, infraaxillary, and infrascapular areas.
Okay. So so usual apex beat, where do you palpate for?
Apex beat normally can be palpable in left fifth intercostal space, 1 centimeter medial to mid clavicular line.
So for this patient, you were not able to palpate the apex beat.
Yes, ma'am.
Okay. So next thing is, how did you palpate for chest movements? Chest expansion, you have told. How did you palpate for chest movement?
Chest movements chest movements can be palpated for, like apical chest movements, the anterior and posterior. Apical movements can be palpated by standing behind the patient and putting arm over the shoulders and ask the patient to breathe. So like that we can see the assess the apical chest movements. In anterior chest movements can be palpated by placing our arm with over the anterior chest wall and with the thumb approximating our both thumbs in front and asking the patient to breathe.
Okay, so the chest expansion was, what is a normal chest expansion in an adult?
3 to 5 centimeters normal expansion.
Normal chest expansion. So this patient had a restricted chest expansion.
Chest expansion.
Okay. Next, how do you define vocal fremitus?
Vocal fremitus is the vibratory sensation which we can appreciate with our ulnar border of our hand while the patient is asked to repeat 111 or 99.
Okay. So in which conditions will you anticipate the vocal fremitus?
Vocal fremitus can be decreased in pleural effusion, can be increased in consolidation.
Okay, very good. Okay, so any other palpatory things which you have left? Nodes, any cervical nodes, any axillary nodes?
All no
No
lymph
nodes,
nodes are not palpable, ma'am.
not
And nothing could
palpable.
be appreciated, ma'am.
Okay, okay. Then proceed to percussion.
On percussion, direct percussion on clavicle was resonant. All areas were resonant except there were stony dullness on left mammary, axillary, infraaxillary, and infrascapular areas. On
Okay,
tidal
so
percussion was also resonant.
okay, so now I just want you to tell what are the sites of percussion so that everybody could hear.
Uh, direct percussion over clavicle, which we
Okay.
are doing on medial 1/3 of clavicle, and
Okay.
the other areas are mammary, axillary, infraaxillary, uh, upper scapular, I mean supraclavicular, infraclavicular, upper scapular, interscapular, and infrascapular areas.
Okay, so the point which we are going to take here is initially there was mammary and inframammary. Now they've taken up the term of inframammary. It is only mammary. So supraclavicular, infraclavicular, and mammary. Axillary, infraaxillary, suprascapular, interscapular, and infrascapular. So there is no inframammary now. So all the places you have percussed and you have found that there is a dullness on the left side of the chest. Is it
Yes,
Atila?
ma'am.
Yeah.
Yes,
Okay.
ma'am.
Good. Okay. So you say if you have noticed dullness, name some conditions where there are dullness.
Dullness can be present in consolidation.
Okay.
Um,
Can there be dullness in consolidation or no?
Ma'am.
So okay, tell
Hello.
me consolidation. Then
Pleural effusion.
okay.
Then
Collapse.
fibrosis, ma'am.
Fibrosis, collapse. Okay. So name some condition where that you usually it is stony dullness in
Stony dullness in pleural effusion, ma'am, and the other
pleural effusion.
empyema.
Yeah. So stony dullness and dullness. Stony dullness is usually seen in when there is a fluid or a pus. So it is usually tuberculosis or it is usually an effusion or it should be an empyema in a stony dullness.
Yes,
Okay.
ma'am.
Okay. Then proceed to auscultation, Tila.
On auscultation, breath sounds were decreased on left mammary, axillary, infraaxillary, and infrascapular areas. There were no, I could appreciate normal vesicular breath sounds in other areas. Added sounds could not be appreciable. Vocal resonance decreased on left mammary, axillary, infraaxillary, and infrascapular areas.
Okay. So now you have told about vocal resonance. What does that mean?
Ma'am,
Define
vocal
resonance.
resonance is the voice sound heard with the chest piece of the stethoscope when the patient is asked to speak, ma'am.
Okay. So what is normal vesicular breath sounds and bronchial breath sounds?
In normal vesicular breath sounds, there will be breath sounds can be heard in throughout the inspiration and the early stage of expiration without a pause. In bronchial breath sounds will be equally heard in both the inspiration and expiration with the pause in between.
Okay. Bronchial breath sounds are heard in which conditions? Name two conditions.
Bronchial breath sounds can be heard in consolidation,
Hmm.
cavity, uh, bronchopleural.
So cavity and consolidation. Cavity and consolidation. Okay. Okay. Then proceed. Proceed to the next slide. So what about the other systemic examination? You have completed respiratory system. How was the CVS? How was the abdomen?
Okay, ma'am, on the CVS cardiovascular system examination, on auscultation, S1, S2 was heard. There was no added sounds or no murmurs.
Okay.
On per abdomen examination, it was soft, not distended, no organomegaly, no tenderness. On CNS examination, the higher mental functions were normal, power was normal, tone normal, reflexes were normal in all the limbs, and patient was having a normal gait.
Okay.
Sensory
So
system examination was normal, skull and spine was normal.
okay. So now you summarize your history and your positive findings.
Okay. 30-year-old male patient who is a chronic smoker and a chronic alcoholic who have a contact history with a TB patient, presented with complaints of weight loss since 3 months, a fever since 20 days, cough with expectoration since 1 week, and a breathlessness since 2 days. On examination, patient was tachypneic, ill-nourished, saturation was low. On inspection, trachea appears to be deviated to right side. Chest movements were decreased. Apex speed was not palpable on palpation. Chest movements were decreased. Trachea was shifted to right side. And, chest expansion was also decreased. On auscultation, on percussion, I could appreciate stony dullness over left mammary, axillary, infraaxillary, and infrascapular areas. On auscultation, breath sounds were decreased on left mammary, axillary, infraaxillary, infrascapular areas. And vocal resonance and vocal fremitus both were decreased on left mammary, axillary, and infraaxillary, and infrascapular areas.
Okay, so now we have summarized the history. Did you comment about parotid enlargement in this patient? What is the importance of parotid enlargement in this patient?
Actually, this patient was not having parotid enlargement. If it was there, like a patient, since he is a chronic alcoholic patient, chronic liver, alcoholic liver disease, if it is present now, we can have a like bilateral parotid enlargement.
Okay, this patient did not have any hepatomegaly. He didn't have any tender hepatomegaly because he had been a chronic alcoholic for more than 10 years. Did he have any hepatomegaly?
Clinically, it was not palpable.
Okay, he was not icteric. So he wasn't having any signs of liver cell failure. No.
No, ma'am.
Okay. So what is your probable diagnosis on this history and general examination?
My probable diagnosis is left-sided moderate pleural effusion, probably due to tuberculous etiology with no respiratory failure. And these are like pneumonia, malignancy, acute pancreatitis.
Okay, so why did you comment about left pancreatitis?
In acute pancreatitis, left-sided pleural effusion can be present, ma'am.
Okay. So your diagnosis, so in Indian setup, the most common diagnosis in a pleural effusion can be tuberculosis. So how do you proceed with this patient? Now we have you have diagnosed a patient having a left-sided pleural effusion. He's a 30-year-old male who's got a history of fever, cough with expectoration, weight loss, evening rise of temperature, and your examination shows that there is a left-sided moderate pleural effusion. So how do you proceed with this patient now?
We are proceeding with the blood investigations. The initial blood investigations like a complete blood count to rule out any infections.
Okay.
Renal function test.
Now wait, Atila. So I just want you to know it's a complete blood count. So what do you expect in a blood count in a patient with tuberculosis?
Patient can have a total count increased, and lymphocytosis can be present in tuberculosis in differential count. ESR can be elevated more than 100.
Okay,
yeah.
so you have told me that there is a increased total count, or is it a normal total count in tuberculosis?
Total count can be.
So one take home message in this point is the patient in this tuberculosis patient, the patient may have a total count of around less than 10,000. It is not necessarily that here the patient has to go with high total count. So whenever there is a fever history, whenever there is a weight loss history, so whenever there is a cough with expectoration, the total count in tuberculosis you expect below 10,000. So that is one of the clenching points saying that it is tuberculosis. And in your differential count, your lymphocytic predominance will be there. And the ESR will be high, which is around 100. So I just want you to know what other conditions can ESR be raised to around 100? Name two conditions.
Multiple myeloma.
Very good. One more. Tuberculosis, multiple myeloma. Then? chronic UTI, chronic anemia, so you can have raised ESR. Yeah, chronic UTI, chronic anemia can have raised ESR. So how about the platelets in tuberculosis?
Platelets can be
Platelets
normal.
can be normal.
Non
Yeah, so
platelets
can the platelets be high, 5 or 6 lakhs?
if there is anemia, reactive thrombosis can
Yeah,
be there.
so with the platelets normal level, which is around 1.5 to 4 lakhs, it can be even to 5 or 6, which is due to reactive thrombocytosis following anemia in tuberculosis. Okay.
Mm.
Okay, so then you are proceeding with your completed your CBC. Then what else you will do?
Renal function test, liver function test can be done.
Okay, okay. Then
Chest X-ray.
okay,
For chest X-ray, PA view can be done.
okay. So
USG can be
why do you want a PA view, not AP view?
done.
Why chest X-ray is taken in PA view than AP view?
In APV, we cannot comment about the actual, actual picture of the lungs and heart.
So in AP view, cardiac shadows are more. So we want to take a PA view so the lungs are visualized better.
Yes, ma'am.
Okay. So this is a
Yes, ma'am.
respiratory case. So we want to take a PA view.
PA view.
So in this patient, what would be the X-ray finding?
There can be homogeneous opacity.
So how do you differentiate between a non-homogeneous and a homogeneous opacity in an X-ray? What do you mean by homogeneous?
There will be uniform opacification in a zone in homogeneous opacity, and there can be loss of costophrenic, obliteration of costophrenic and costophrenic and cardiophrenic angle.
Okay, so homogeneous opacity means that is full whitening. So non-homogeneous opacity, in between the white there can be air bronchograms. So there can be black patches in between. So that's how you differentiate between a homogeneous opacity and a non-homogeneous opacity. Homogeneous opacity are usually seen in fluid collections like pleural effusion, empyema. Non-homogeneous opacities are usually seen in consolidation.
Consolidation.
Okay, so now this patient should have a homogeneous opacity. So what is the amount of fluid that you can see with the X-ray and with an ultrasound?
With the X-ray, there should be 150 ml, at least 150 ml of fluid should be there. Then only it will be evident on X-ray.
Okay.
Then US ultrasound scan, 30 ml can be needed. That much is enough to be evident on USG scan.
Okay, super. So okay, well then how do you? So if the patient has got how will you classify mild, moderate, and massive pleural effusion?
A mild pleural effusion means amount of pleural fluid is less than 500. 500 to 1000 ml means moderate pleural effusion, and the fluid collection is more than 1 liter. It is massive pleural effusion.
Okay, so now if suppose the patient has got a mild pleural effusion, so and you're able to see only 150 ml. So what is the chance of whether you want to aspirate it or you want to just give a course of antibiotic and wait?
For diagnostic tapping can be done.
Okay, so what diagnostic tapping can be done with the help of
Ultrasound guided tapping.
Okay, so you're going to go for an ultrasound guided pleural tapping or a CT guided pleural tapping. Which is the better mode of method mode of radiology in pleural effusion, whether it is ultrasound chest or it is a CT chest?
And for tapping,
Yeah.
for tapping, it is better to do under ultrasound, USG guided tapping can be better.
Okay. So in a setup where it is a primary health care, if you want to tap by looking only into the X-ray, so what is the amount of fluid do you want to aspirate without getting it from ultrasound or CT?
Ma'am, can you ask once more? I didn't understand, ma'am.
So actually, when the fluid is less than 150 ml or 100, you can aspirate through ultrasound or CT. But you are going to be in a primary care and you want to aspirate. So how much fluid actually should be present to aspirate without ultrasound or CT? So the fluid should be more than 200 to 300 ml. So one other point which can be taken is when the pleural effusion, which is seen by the X-ray, is more than 2 centimeters on the costophrenic angle.
Okay, ma'am.
Am I clear?
Yes, ma'am.
So you are in a primary health center where you want to tap the pleural fluid, where there is no ultrasound machine or a CT machine, but still you are suspecting tuberculosis and you want to aspirate. So, but how do you aspirate? How do you know that there is a definitely fluid so that I can put a needle and tap the fluid out? So I'm sure that I can take a fluid only with the X-ray. I'm not able to confirm the fluid by ultrasound. I'm not able to confirm the fluid by CT. Then the costophrenic angle haziness. On the costophrenic angle, it should be more than 2 centimeters of homogeneous opacity. Then there is definitely pleural effusion. So you can definitely proceed with pleural tapping. Am I clear now?
Okay, ma'am. Yes, ma'am.
Okay. So costophrenic angle, 2 centimeter haziness, homogeneous opacity, you can definitely tap in a primary health center. Okay. Without the help of ultrasound and CT.
Okay, ma'am.
Okay. So now you have tapped what? You have tapped the pleural effusion. Now what all investigations are you going to send in pleural effusion? Pleural fluid.
Yeah, pleural fluid, cell count can be done. Total count, differential count, pleural fluid protein.
Pleural fluid. Okay. What is the cell count you expect in tuberculosis?
In tuberculosis, lymphocytosis will be there.
Okay, so lymphocytosis will be there. So in cell count, you will expect lymphocytosis. If suppose it's a neutrophilic predominance, what is your differential diagnosis?
Other infectious hosts like pneumonia can be present.
So it can be a pneumonic effusion, one thing. Okay, neutrophilic predominance. Okay. Okay, then.
Yes, ma'am. Then, ma'am, empyema, there will be neutrophils more than 50,000.
50,000. Okay, if suppose it's more amount of RBCs, so what is your differential diagnosis on? Pleural fluid, more RBCs.
Ma'am, traumatic tapping can be a possibility. Malignancy can be a possibility.
Very good. So if there is eosinophils, what is your differential diagnosis on?
Like parasitic infections can cause eosinophils, like the Paragonymous westermanni. Then other cause can be Church-Strauss syndrome. Then
Very good.
pneumothorax can have eosinophilia.
Yeah. So eosinophils, you usually think about Church-Strauss, parasitic infection, pulmonary embolism, pulmonary infarction, hemothorax. Okay. So you have talked about the cell counts. Then what other things you will send?
Pleural fluid protein, pleural fluid glucose, adenosine deaminase, LDH can be sent. Like pleural fluid AFB culture can be sent, gram stain can be sent. Then pleural fluid cytology and cell block can be sent to rule out any malignancy.
Okay, so now from your inference, if it is tuberculosis how will be the protein and glucose?
In tuberculosis, like protein can be high, glucose can be low as it is a bacterial infection. And
Okay. Okay. So then what about your LDH?
LDH can be, if LDH is more than 200, we can we can say like it can be tuberculosis
Okay.
or any
So
bacterial.
okay. So if LDH is more than 1000, what does it mean? So more than 200, you're thinking about tuberculosis. If it is more than 1000, you have to think about empyema. Okay. 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 Then you have told about ADA. What is the inference of ADA in pleural fluid?
If adenosine, I mean ADA is more than 45, it can be tuberculosis.
Okay. So
ADA,
the most so I just wanted to tell you that pleural fluid ADA is more sensitive and specific, because there was ADA of more than 40, you are confirming a diagnosis of tuberculosis with the support of protein and glucose. That's it. Okay, so the ADA in pleural fluid is very sensitive. ADA in CSF, what is your inference on ADA? You want to rule out TB meningitis. You have done a LP. The ADA in CSF, how much it should be? So ADA in pleural fluid should be more than 40 to diagnose tuberculosis. ADA should be more than 20 in case of CSF. TB meningitis, it is only ADA of 20. Pleural fluid, ADA of 40. Okay, more than 40. But usually some of the neurologists do not take ADA as a sensitive marker, but in our hospital we do take ADA in CSF as a sensitive marker to diagnose tuberculosis. Okay. Then what about cell block and cytology? What is the difference between cell block and cytology? What is the difference between? Tell me.
Both are used to diagnose malignancy. In cytology, only little like 5 to 10 ml of fluid is needed for diagnosis, but in cell block more amount of fluid should be needed, like 150 ml of fluid should be needed for diagnosis. Hello.
Okay. So like
Hello, ma'am, can you hear me?
Yeah, I'm hearing.
Hello?
So what is the role? Yeah, I'm hearing you. Atila? Hello?
Hello?
Yeah, are you hearing me, Atila?
Yes, ma'am, I can hear.
One other thing is, what about TB-PCR, polymerase chain reaction? What about TB-PCR in pleural fluid?
It is a more specific. It can be used to. It can be used as a more specific diagnosis.
Okay, so what is the sensitivity of TB-PCR in pleural fluid? Yeah, what is the sensitivity of TB-PCR in pleural fluid?
60 to 75%.
Yeah, so 60 to 70%, but still, so you are not getting suppose I'm just giving you a history, like you are suspecting tuberculosis, you have aspirated the pleural fluid, but none of the pleural fluid investigations are conclusive for tuberculosis, but still you want to start ATT. So how will you proceed with? How will you proceed with?
We can start ATT based on.
So one other thing is what we can do is what we can do is if you are in strong suspicion of tuberculosis and you are not getting a proper diagnosis on pleural fluid, one thing is we can go for a pleural biopsy as
Okay, ma'am.
CT guided pleural biopsy, as there can be granuloma deposition on the pleura also.
Okay, ma'am.
Okay. Okay. So now, so you can proceed with the CT guided pleural biopsy and diagnose tuberculosis. Okay. So
Okay,
in this patient, you have diagnosed by aspirating the fluid. What is Sillout sign in X-ray?
Sillout sign is the loss of
So
normal
the curve,
contour of X-ray on right side, right lung border and the heart border, and also the right lung border and the phrenic border.
okay. Okay. Sorry. Okay, you have diagnosed tuberculosis in this patient. So, what is the role of Manto in this patient?
And what's the role of
Manto test.
okay, okay. In Manto test is a screening test that can be used. It can detect both active and latent infection.
Okay, so if suppose this patient has a Manto positivity of 10 millimeter, will you proceed only with Manto?
No, ma'am.
No. So, so for a normal person, if you put Manto also, it can be positive. Why?
Because of BCG vaccination, Manto can be positive.
So we are all exposed, yeah, because of one thing is due to BCG vaccination, and all of us would have been exposed to tuberculosis bacilli. So we can be Manto positive also. So it is only not only you cannot depend only on the Manto to start ATT.
Yes,
Okay, but in immunocompromised patients, is Manto specific?
in immunocompromised patient, Manto is of no use as it will be negative, ma'am.
It can be positive in immunocompromised patients. Sometimes even a HIV patient, if you're in a strong suspicion of tuberculosis, if the Manto test, if the Manto is even positive for about 7 millimeter, we do start with ATT because co-infection of HIV and TB is more common in our country. Okay. Okay. So next. So what is the role of IGRA? As Ramya ma'am had messaged, what is the role of IGRA? What is IGRA?
I don't know, ma'am.
Okay, so IGRA is it is being told as the gold standard for diagnosis of tuberculosis through blood, but the sensitivity and specificity is around 50-50. So we do sometimes proceed with there is no other clue of tuberculosis. We do IGRA, but the most specific is diagnosing through pleural effusion tapping. Okay.
Ma'am.
Okay. So how do you treat this patient then?
Treatment.
How do you treat this patient?
Tap.
So you will start ATT.
Start ATT. It can be first line drugs are isoniazid, rifampicin. Yes, ma'am.
Rifampicin. So what is the dosage of isoniazid? How do you start? HR is at yeah. HR is at T. So what are the doses of all these 4 drugs? INH of
INH, ma'am, isoniazid 5 mg per kg, maximum of 300 mg can be given, ma'am.
Okay. Okay. Rifampicin.
Rifampicin 15 mg.
10 10 mg kilogram.
10 mg per kg.
Okay.
Maximum, ma'am.
Tell me, I'm
Maximum
hearing.
1000 gram. Maximum
the
900 mg can be given per day.
No. So INH, the maximum dose is 300. Rifampicin, the maximum dose is 600. Ethambutol, the maximum dose is 1200. Pyrazinamide, the maximum dose is 2000. But since pyrazinamide is hepatotoxic, we usually don't prefer going for 2000. We usually start with 1000. If the patient is tolerating, then we switch over to 1500. If the patient is obese also, we don't go for 2000 because it is more hepatotoxic. So the maximum dose of INH is 300. Rifampicin is 600. Ethambutol is 1200. Pyrazinamide is 2000. Okay? Okay, Atila? Okay. So then the okay. So the next thing is, what is the role of adding Benadryl in this patient? Pyridoxine. Why do you add pyridoxine?
Because isoniazid can cause peripheral neuropathy. So to prevent that, along with the ATT, we are giving pyridoxine.
Okay. So what are the side
To
effects do you
prevent
expect in INH? What side effects do you expect in ATT? INH.
Yes, ma'am. Peripheral neuropathy can be present. Rashes
Then,
can be present. Hepatitis can be present.
Then
for red colored
so
can be
INH you can have psychosis. INH psychosis is more common. So psychosis you have to think about.
Ethambutol, optic neuritis can be present.
Okay.
And pyrazinamide
Okay. So INH. Okay. Now you tell me.
Hello, ma'am.
Adila, are you hearing me? So can psychosis be present in INH?
Ma'am,
Can INH be present? Yeah, tell me, Adila. Tell me, Atila. Atila? Okay. So INH psychosis can also be present. Okay. So we've already talked about
ma'am.
gene. Yeah. Are you hearing me?
Yeah. Yes, ma'am. Now we can hear you.
Okay. So INH psychosis can be seen. So if suppose the patient is being diagnosed as tuberculosis, then what is the duration of treatment you are going to proceed with?
Ma'am, it can be present.
What is the duration of treatment? So the duration of treatment is usually 6 months.
Ma'am, yes, ma'am. Now I can hear you. In between,
So the
I could not hear you, ma'am.
Oh, I'm sorry. Okay. So the duration of treatment is 6 months.
6 months, ma'am.
6 months.
Yes,
So 2 months.
If it is a drug sensitive tuberculosis.
Yeah, if it is a drug sensitive tuberculosis. So 2 months of HRZT and 4 months of HRE. Yeah.
Yes, ma'am. Yes, ma'am.
Okay. So what about MDR TB? If it is drug resistant TB, what are the drugs?
If it is drug resistant TB, then we have to opt for second line drugs like bedaquiline.
What are the newer drugs?
Linezolid, bupropion, and clofazimine, cyclosporine.
Okay.
Delamine and bedaquiline can be given for 18 to 24 months. And
Okay, so MDR TB, what is the duration of your second line drug?
others can be given
What is the duration of second
6
line drug?
months. ma'am.
It is actually 1.5 years to 2 years. So MDR TB and XDR TB treatment should be continued for 1.5 years to 2 years. Okay, Atila?
Ma'am, 18 to 24 months we can give
18
in
to
MDR
24
TB.
months. Yeah, so 18 to 24 months. Okay,
Yes,
so
Yes,
Ramya ma'am has
ma'am.
commented how many drugs can be added to MDR drugs, but depends upon the sensitivity because we are going to send CBNAT. What is CBNAT? What is CBNAT, Atila? So we are going to
CBNAT
find out the what.
Based nucleic acid amplification test. Cartridge based.
So CBNAT is you are getting a specimen or a sputum sent for drug sensitivity pattern. Usually the drugs seen in CBNAT or INH and arsen. So INH and arsen resistance will be shown in CBNAT. But there is a
Based nucleic acid amplification test.
actually I'm not hearing you properly. Okay, tell me. Atila, you are hearing me? Atila?
Based
Are you
on
hearing?
PCR
I'm not. Okay, so the drugs on the there can be, as ma'am said, there can be 4 to 5 drugs. So depending upon the sensitivity, we are going to add. So the duration of treatment for MDR TB is 18 months to 24 months. The newer drugs like bedaquiline and Delamant has been used. Rifabutin has been also in use, but depending upon the drug sensitivity pattern, we usually treat MDR and XDR TB. Okay. Okay. Atila? Atila? Atila?
Ramya, you are actually audible to all of us, I think. Only Akila's internet connection needs to be checked, I guess.
Oh, okay, okay, ma'am. So I'm not hearing whatever she's saying. Okay, ma'am. I think she lost connection. So
You are audible clearly to all of us, I think. At least for me, you are clearly audible.
yeah, okay, ma'am. I'm audible to you. Even I can hear, but Atila's thing, I'm not getting it properly. Atila, you're here?
Can you hear me, ma'am?
Yeah, I can hear you now. You tell me, like we have just discussed about MDR-TB and XDR-TB. So we have discussed about CBNAT. CBNAT is going to tell about the drug sensitivity for MDR and XDR-TB. It is going to be 4 to 5 drugs and a duration of 18 to 24 according to the sensitivity pattern. Okay, that's what I told you. Okay. So now you can share the slides on tuberculosis. What is Light's criteria? Light's criteria. So anyone from the audience can tell what's Light's criteria, they can chat. Yeah.
Ma'am, can you
Yeah. What's Light's criteria?
other
So Light's criteria. So as I'm not able to get Atila, so you usually see pleural fluid. There is a Light's criteria. So we all know it is an Alahapan book. The Lights criteria depends upon the pleural fluid and serum, pleural fluid protein and serum protein. The ratio should be more than 0.5, or the pleural fluid bar serum LDH ratio should be more than 0.6. Okay, so pleural fluid protein and serum protein ratio should be more than 0.5. Okay, so pleural fluid and serum fluid LDH ratio should be more than 0.6. Another thing is pleural fluid LDH is more than 2/3 of the upper limit of the normal LDH level. So this is Light's criteria. So we can diagnose whether it is an exudative or transudative. So we have few conditions where it is transudative. So Atila has shared, I think, few conditions of transudates and exudates. So you can differentiate whether it's a transudate or an exudate according to the Light's criteria, and we can proceed according to your diagnosis. Okay, so there are some conditions where you needn't have to go for Light's criteria. So what are the two conditions? When the pleural fluid protein is more than 2.9, you do not, it is definitely a exudate. And the so can you check for what is the role of cholesterol checking in pleural fluid? Can anybody say pleural fluid cholesterol? Pleural fluid cholesterol. So pleural fluid cholesterol of more than 45 chylothorax. As ma'am said, it is chylothorax. So more than 45 it is usually exudative and it is seen in chylothorax. Okay. So okay, so you have diagnosed in this case, you have diagnosed a tuberculosis. You have started with ATT. So if suppose I just want to know what is the duration of treatment in TB lymphadenitis? TB duration in TB lymphadenitis, TB duration in sputum positive tuberculosis, duration in disseminated tuberculosis. Yeah, in exudative it is cholesterol is high, as I have said. What is the duration of ATT in TB lymphadenitis? Atila, you're hearing me, Atila? I think she can only share the slide. As the duration of ATT in this patient, it is usually 6 months. We assess the patient by doing an X-ray every month to know the improvement. If suppose the X-ray is taken after 2 months and you still feel there is a residual pleural effusion, the intensive phase of ATT can be continued for 1 more month. Means 2 months of intensive phase can be continued to 3 more months. So, and then you can switch over to continuation phase. If suppose the pleural effusion has subsided well on the 2nd month of the X-ray, then you can switch over to continuation phase. If suppose the 6 months of ATT is complete and you want to know whether the ATT can be stopped or not, then you can do a CT or an X-ray to assess how the lung is. And then if you feel there is still residual pleural effusion or residual disease, you can continue the ATT for 3 more months. So a total of 6 to 9 months ATT can be taken in this case of pleural effusion. So if in TB lymphadenitis, cervical lymphadenitis, the ATT can be continued for 6 to 9 months. In TB meningitis, the role of the duration of treatment of tuberculosis is usually 18 months to 24 months. And in disseminated TB, the duration of treatment is around 12 to 18 months. Okay, so I just want to ask one more question. Role of steroids in tuberculosis. Which condition steroids can be used in tuberculosis? Anybody? So it can be in tuberculous meningitis, as ma'am said. One more. There are 3. From pericarditis. Very good, ma'am. One more. So there are 3 conditions where you can use steroids in tuberculosis. Number 1 is, as ma'am said, it is tuberculous meningitis, which has to be given for 2 months. Tuberculous pericarditis, which has to be given for 2 months. and in a massive pleural effusion, which is compromising the respiration, then you can give a low dose of steroids for about 1 to 1.5 months. What is the role of steroids in TB, meningitis, and pericarditis? Why do we give steroids? Anyone? The role of steroids in TB, meningitis, and pericarditis is to prevent fibrosis. So it can even cause fibrosis of the meninges. It can be fibrosis of the pericardium, which can cause pericardial constriction. So constrictive pericarditis may be one of the most common complication in TB pericarditis. So to prevent inflammation of the meninges, to prevent inflammation of the pericardium, we give a course of steroids for about 1.5 to 2 months for prevention of fibrosis. Okay. Is there anything else we can discuss?
Akila, are you there? I have an interesting question for you if you're there.
Atila? Yeah.
Okay, anybody can pitch in. Somebody was sputum positive by gene expert. Then is there a test of cure for this person? Or if WHO says give 6 months of ATT, will you stop after 6 months of ATT? Then somebody says no, let's do one more gene expert and confirm whether this guy is really positive or really negative. So you do a gene expert and he comes positive. So will you still treat this patient?
So sputum positive, then you have to take, you have completed 6 months of ATT. So it means.
Hey, madam, my question was for PGs. I can't question you.
No. If nobody is answering, I can tell you. Okay, no issues. Okay. Atila, if you're here, you can answer, Atila. Or anybody else also can answer.
Okay, basically, I just wanted to convey for sputum TB, you can't use gene expert as test of cure. Oh, Akila, you're there? Yes, please go ahead.
Yeah.
Adila, maybe you can switch off your video and probably try to answer. Or any of the PGs, anybody wants to take that question? Maybe you can answer, Ramya.
Okay, I just wanted to emphasize, don't use gene expert as test of cure because it can also pick up dead bacilli. So it is more of a clinical diagnosis and resolution. Maybe you can back it up with radiology by imaging. Some opacity which was there previously has gone. Clinically, we can use weight gain and symptom, reduction in symptoms.
Can you hear?
More of a clinical diagnosis rather than microbiological diagnosis for stopping ATT. So I just wanted to emphasize this.
Ma'am?
Yes, good point, good point. Yes, Adila, we can hear you in between. We can hear only when she says ma'am.
Okay, any other questions, Adila?
Anything else? Anything else anyone wants to say?
Adila, if this patient was HIV positive, so what will you start first? ATT or ART? I wanted to ask few more things. If you could have mentioned the weight of the patient in the case sheet, or I think I probably missed it, sorry. Weight and BMI, that would have been a little bit more helpful. Okay, we'll just assume BMI is around less than 18 and you did a HIV test and it comes positive. So will you start, and you also do a culture and AFP culture also comes positive. Gene expert is also positive. So final diagnosis, this guy is having TB pleural effusion in the background of HIV. So what next step will you do? Will you start ATT, ART?
Ma'am, can you hear me?
Yeah, Adila, I'm here. We are all hearing you. Talk. I think she goes on and off, ma'am. Ramya, ma'am, you can
Yeah.
just.
Yeah, I will go ahead. Okay, so
Yeah.
first thing is minimum duration.
Okay, ma'am.
Generally,
Actually, now only I
highest risk of
got-
iris. Yes,
Sorry,
Adila, are you
it
able
got
to hear
connected,
me?
ma'am. There was
Yeah,
some
check your
error
net
in
connection.
between.
I have got few comments. All of them are right.
First, we have
ART
to start
followed by
ATT.
ATT. The main reason is risk of activation of iris.
ATT
So
is first, and after 2 weeks only ART should be started.
how
Ma'am, I can
do you
hear
say
you,
it
ma'am.
is 2 weeks? Yes. How do you say it is 2 weeks? The duration is actually 2 to 8 weeks. If CD4 is less than 50, you can start by 2 weeks. If it is more, then you wait till 8 weeks, then start. So before starting ATT, always confirm that is HIV negative. Otherwise, you're you're going to induce iris. So after starting ATT, his symptoms will worsen. And then you'll start thinking, probably this was MDR TB and you have started wrong medication. Or this was some malignancy and you will start doubting your gene expert, which is like 95% sensitive. So just doing one simple HIV test, you will get to know what you can start next and how you will follow up the patient.
Okay.
I think rest all points were very well discussed and very well covered. I think of anything, I'll put up in the comment section. Thank you.
Ma'am, is there? Thank you, ma'am. Is there any other question from the crowd?
Maybe you can just summarize, Dr. Pranita. Maybe like you want to wrap up. That's all. Anything?
Yes, ma'am. I think we have widely discussed about tuberculosis. So the main thing, as Ramya ma'am was telling, so HIV has to be ruled out before starting an ATT. Manto is not that specific. IGRA is, even though gold standard, we don't usually prefer for IGRA. So the most important diagnosis is by pleural fluid analysis or a tissue biopsy. So ATT has to be calculated according to the weight and started. So the clinical improvement has to be assessed, and the duration of treatment is depending upon the clinical improvement. And you can extend even 3 more months of continuation phase according to the improvement of the patient. Continuation phase according to the clinical improvement of the patient.
Yes,
okay.
Perfect. Yes.
Okay. So the one other clinical improvement by weight gain. So that is also one good clinical indication that the patient is improving on well. So there are lots of MDR TB and XDR TB which is coming up in India. So we should educate the patient regarding continuation of ATT without stasis. So many of the patients are not being told that you are supposed to continue ATT for 6 months. They're given prescriptions, and once the prescription is over, they stop it. They don't know that it has to be continued for six months. So that's why the government has taken steps to as dots and things like signing them up, giving the medications in hand, and making sure that they are eating. So whenever you are prescribing ATT, you are supposed to educate the patient that the continuation of ATT is more important, and the patient has to come every month for follow-up, for assessment of the patient clinically as well as radiologically, so that we have to continue the ATT. And sometimes I totally forgot talking about liver function test in ATT. So we are supposed to, liver toxicity is more. So the patient, whenever the patient comes, you're supposed to check for uric acid in case of pyrazinamide, because there is hyperuricemia, and liver function test in every month, as INH, arsenic, and pyrazinamide are more prone to cause hepatotoxicity. So there is one more question to Atila. So OTPT of how much is needed for continuation of ATT? Atila, you're here, or do you want me to continue? I think Atila lost. So
frozen.
no, ma'am. Then I will talk. Attila, what is the?
No, ma'am,
what is the-
I can hear you.
Yeah, okay. What is the
I
normal
can hear
OTPT?
you, ma'am.
Yeah.
I
So
can
LFT,
hear you, ma'am.
what is the normal OTPT?
Ma'am,
Okay. Okay.
Attila, I think your network is quite poor. No problem.
Yeah, I will tell, ma'am. So whenever the patient comes for review, you are going to do your LFT. So LFT normal is around 40. Attila, you are not hearing. I will tell.
ma'am, LFT, I'm not.
So LFT, so you are going to monitor LFT every month with the patient. So what is their inference on if the LFT is more than around 150? What are you going to do with ADT? So I will tell. So actually, when the OTPT should be around 40. So if the patient is asymptomatic, there is no signs of itching, no signs of vomiting, no signs of jaundice, then the ATT can be continued, even though the OTPT is around 120. But if the patient is symptomatic, I think you have to discontinue ATG, first line drugs, and you're supposed to start with second line drugs, which are levofloxacin and ethambutol. Initially, they used to add injection streptomycin along with ethambutol and levofloxacin. Now, the latest guideline says no need streptomycin, it is only ethambutol and levofloxacin. So after a course of levofloxacin and ethambutol for about 2 to 3 weeks, you repeat an LFT, and if the LFT is improving, means the OTPT has come down to 40, you reintroduce one drug at every week. So the first drug to be introduced is arsen in a lower dose of around 300. Then the second drug is INH, and sometimes pyrazinamide, or sometimes according to the physician, we usually don't start pyrazinamide because it's hepatotoxic, and we usually continue with INH, arsen and ethambutol for a duration of 9 months instead of 6 months. Okay. Ma'am, is there any other doubt?
No, I think
Anybody?
this was good summarization and really good point by point discussion.
Okay, ma'am. Thank you. Thank you.
Really great. Yeah. I think given the recording will really help the PG students who haven't joined today.
Okay,
So,
ma'am.
Sunita madam, hats off, very in-depth and in-patient moderation.
yes, absolutely.
Thank you
Point by
so
point.
much.
Point
Yes.
by point. Yes.
Thank you, ma'am. Thank you.
Yes.
Thank you, ma'am.
So,
Thank you so much,
thank
ma'am.
you
You
so
all
much,
have been
Dr.
patient
Sunita.
enough to
Thank
hear
you.
what we are saying. Thank you so much. Okay.
Thank you to all our
Thank you, ma'am. Thank you, ma'am.
senior faculty for joining tonight.
Yes,
Dr.
ma'am.
Srinivas, Dr. Resmi,
Yes, ma'am.
Dr. Lizzie
Thank you.
was here. I think she has left. So thank you
Oh.
everyone for joining. Yes, Hari, would you want to wrap this up?
Yes, ma'am. Thank you, ma'am. Ma'am, Pranita, ma'am, thank you for accepting
Hari.
to be the moderator.
And thank you,
Thank you.
Adila.
Thank you, Adila.
Thank you, Atila. Yeah. Thank you, Atila.
No,
Thank you, Hari. Thank you, Jyoti, ma'am. Thank you, Ramya, ma'am. Everybody here, ma'am. Thank you.
Thank you, everyone. Thank you, everyone. Good night.